Bom, boa noite a todos. Vamos dar início ao Ground Round de 28 de julho de 2025. Nós hoje temos um Ground Round internacional. A primeira parte vão ser os casos tradicionais, só que vão ser transmitidos apresentados em inglês, né? E a seguir nós temos dois palestrantes ilustres, né? A professora Aik Shukla, da Columbia University. She's already with us. She's already online. Thank you very much for coming, for accepting our invitation. Após a professora Shukla, nós vamos ter o professor Jeffrey Goldberg, direto da University of Stanford. Vamos começar? Então, primeiro caso, Dr. Pedro Fukuyumeta, PGY2. É um trava-língua esse PGY.
So, good evening, everyone. My name is Pedro. I'm a second year resident here in the service. Today, I'm going to present the first case of the night. My supervisor was Dr. Jennifer Lin. The head of the division is Dr. Luis Alberto Jr. And I would like to thank Dr. Leticia Morin for sending the case. The case involves a 63-year-old Caucasian female patient who was born and raised in São Paulo. She was referred to our service due to glaucoma suspect. She was not using any eye drops. She has diabetes and one brother with glaucoma. On ophthalmologic exam, she has best correct visual acuity of 20/20 in both eyes. The intraocular pressure was 18 in the right eye and 15 in the left eye. I will show some photos for the rest of the exam. On the slit lamp exam of the right eye, we can see normal eyelids and eyelashes, nasal pterygium, clear cornea, deep anterior chamber, trophic iris, and the patient is fake. On the slit lamp exam of the left eye, we can see normal eyelids and eyelashes, clear conjunctiva, clear cornea, deep anterior chamber, trophic iris, and the patient is fake too. Gonioscopy exam of the right eye, we can observe an open angle 360 degrees up to the ciliary body band. And on the left eye, we can observe an open angle 360 degrees up to the ciliary body band. On the fundus exam of the right eye, we can see a pink optic disc with cup-to disc ratio of 0.8 by 0.8, inferior temporal notch, normal vessels, and macula. Retina is attached. On the left eye, we can see a pink optic disc with cup-to disc ratio of 0.2 by 0.7, normal vessels and macula, and the retina is attached. So for the diagnostic hypothesis, we have a female patient who was referred for glaucoma suspect. She has intraocular pressure of 18 and 15, an enlarged optic disc cupping, and gonioscopy shows an open angle in both eyes. So we can think of primary open angle glaucoma, normal tension glaucoma, and large physiological optic disc cupping. And for management, we need to investigate glaucoma with central corneal thickness, visual field 24 to 2, and OCT. So she had a central corneal thickness of 575 of the right eye and 564 of the left eye. On the right eye's visual field, the exam was reliable and showed a central defect and a subtle superior nasal step. Repeated exam, and it was a consistent visual field defect. In the left eye, the visual field examination was reliable with dispersed non-specific scotomas. On OCT of the right eye, we can observe a reduction in retinal nerve fibers in the inferior temporal region, which could explain the visual field defect. On the left eye, it was normal. So the patient presented with normal tension glaucoma and was started on travoprost once daily. After 45 days, the intraocular pressure of the right eye decreased to 12 and the left eye to 11. We initiated further investigation, and 24-hour ambulatory blood pressure monitoring revealed nocturnal hypotension, but the patient was not taking any medication for high blood pressure. She had symptoms suggestive of Raynaud's phenomenon, and the exam was negative for obstructive sleep apnea, and the patient had no findings in neurological evaluation. The patient remained stable for about 1 year after suspected progression occurred between 2015 and 2017, with pressures varying from 14 to 16 while on dorzolamide and travoprost. The patient did not respond to timolol and had intolerance to brimonidine. In the photo, we have a glaucoma progression analysis, GPA, showing possible progression in the right eye. At this time, this was a patient's visual field 10 to 2, showing significant central field compromise in the right eye and no alteration in the left eye. So the patient had progression on the right eye despite clinical therapy, so it was indicated SLT on the right eye. 1 month later, the intraocular pressure of the right eye decreased to 12 without medication. Control IOP and no progression in the exams was seen over a year. However, in 2019, the IOP of the right eye was 16 and the left eye was 14. A new progression in the visual field of the right eye was observed. On the right eye's visual field, there was a scotoma in the superior hemifield, threatening fixation. Travoprost was reintroduced, and the intraocular pressure became 12 in both eyes. However, 5 months later, there was new worsening in the right eye. Because of this, timolol was added. The left eye's exam showed a superior defect, but the exam was unreliable. In 2020, due to the COVID pandemic, the patient lost follow-up and returned in 2022, using only travoprost in both eyes. The IOP of the right eye increased to 17, and the left eye increased to 16. The visual field of the right eye worsened again, but there was no progression on the left eye. Timolol was associated again, and the IOP went to 13 in both eyes. This was the visual field in 2022. This is the GPA from the beginning until 2024, where we can observe a progression of the superior defect. From the rate of progression, we see that it showed a value of minus 2.9% per year, and we observe that over these 10 years, the left eye remains stable. On OCT, we observed an inferior defect in the right eye associated with an inferior temporal ganglion cell complex defect. And in the left eye, the pie chart appears normal, but in the double hump curve, there's an inferior temporal fiber loss. In 2025, the patient was on timolol, dorzolamide, and travoprost in the right eye and travoprost in the left eye. Intraocular pressure was 13 in the right eye and 16 in the left eye, and on a fundus examination, an inferior temporal optic disc hemorrhage was detected in the left eye. For discussion, I would like to comment that despite IOP reduction being the main therapeutic goal, many normal attention glaucoma and TG patients progress with normal IOP, suggesting the involvement of IOP-dependent and IOP-independent factors. An IOP reduction of at least 30% is recommended to slow NTG progression, which often requires combination therapy, as monotherapy may be insufficient. Latanoprost, bimatoprost, and timolol are cited as effective in reducing IOP in NTG, but individual response varies. Vascular factors such as ocular blood flow, autoregulation dysfunction are crucial in NTG pathophysiology and contribute to control difficulty, acting independently of IOP. For take-home messages, central and paracentral visual field defects are more common, even in early stages in normal attention glaucoma. IOP reduction remains crucial. Systemic conditions play a bigger role in pathogenesis and progression when compared to primary open-angle glaucoma. Intervene in related systemic conditions when possible, and there are ongoing studies about neuroprotective agents. Thank you.
Pedro, eu vou abrir a discussão em português. The discussion will be in Portuguese because of the audience, and so it can be more productive. And eu tenho uma dúvida. Eu não entendi se o paciente tinha ou não Raynaud, se ele tinha ou não problema de apneia. O que foi que você falou?
Ele tinha sintomas sugestivos de Raynaud, e, ele relatou no prontuário
Não,
que
sim.
às vezes a mão ficava mais forçada. E não tinha. Foi feita a pesquisa para apneia e não tinha apneia.
Você tem um resumo aí do, pelo menos esse campo visual aí?
O resumo de confusão.
Põe o GPA. Paulo Augusto, quer falar? Eu queria só eh, falar da presença da doutora Vilma Leles Barbosa, presidente do Conselho Brasileiro. Bem-vinda, Vilma. E o doutor Marcelo Ratanaka, da Universidade de São Paulo, que também é um dos nossos discutidores hoje para as aulas, né? Paulo Augusto?
Pedro, esse paciente, apesar do SLT, da medicação, não está bem controlado, né? Tanto é que surgiu a hemorragia depois no outro olho, o que prova que ele tem uma evolução e daqui a pouco você vai encontrar talvez uma evolução estrutural e funcional. E agora?
Não é para eles. Acho que aí. Acho que pode ser os universitários, o Luiz Alberto e o Roberto Vessani.
Não, eu quero convidar a Jennifer, que ela pode ou não, por favor, Jennifer, responder essa questão, mas você é aqui fazer seus comentários, né? Senão, aqui o pessoal não deixa ninguém, nem outras pessoas falar, entendeu? Então, pode fazer seus comentários a respeito do caso e, se quiser, pode responder a questão do professor Paulo Augusto.
Boa noite a todos. Então, aqui a gente trouxe esse caso mais para ilustrar um caso de glaucoma de pressão normal, né? E a dificuldade que a gente tem muitas vezes de controlar esses pacientes, porque justamente eles vêm já com a pressão abaixo de 20, a gente coloca colírio, faz SLT. Teoricamente, a pressão-alvo que a paciente, a gente observou até, doutor Paulo, que a paciente ficava sem progressão durante os anos, seria em torno de 10, no máximo 12, que foi colocado como pressão-alvo para ela. Todas as vezes que ela progrediu, ela veio com uma pressão um pouquinho mais alta, 14, 16, depois da pandemia ela voltou com pressão de 17, então essa seria a pressão-alvo dela. No caso da última situação, onde ela apareceu com hemorragia de disco, daí foi adicionado o timolol. Mas, por exemplo, o olho direito, que já está um glaucoma avançado, se ela progredir de novo, já está com 3 medicações, tem que até pensar já em uma cirurgia. E aí fica também a dificuldade, você vai fazer, por exemplo, uma trabeculectomia, mas diminuir essa pressão para quanto, né? Que às vezes ela, nessa última ela estava com pressão de 13, se eu não me engano, no olho direito, que é o mais avançado. Então tem a questão de você também não deixar reduzir demais para não ter maculopatia hipotônica e tudo isso, tem essas questões. Mas também comentar da dificuldade que a gente tem de muitas vezes a gente conseguir manter uma pressão que teoricamente a gente acha que é a pressão-alvo do paciente, mas o paciente progredir mesmo assim, provavelmente por conta desses fatores não relacionados à pressão intraocular, né? Desregulação vascular.
A hemorragia recente do olho esquerdo que demonstra que ela não está bem controlada, né? E é uma paciente que não tem um bom compliance. Ela suspende por conta própria o colírio, não usa tal. Então, essa é uma abordagem importante na conduta, porque é alguém jovem que tem muito tempo pela frente, hein?
Sim, com certeza.
E com a progressão evidente, né? Vessani,
Só um comentáriozinho rápido.
só falar mais perto.
O caso está super bem documentado, parabéns, os campos visuais. E o caso mostra claramente uma progressão importante nesse tempo, intervalo de tempo de quantos anos, Alice?
Foram 11 anos.
11 anos, né? Mas é uma progressão importante. O paciente está com que idade agora?
73, né?
70 e poucos. A Jennifer,
73.
Jennifer fez excelentes colocações sobre a questão de como conduzir o caso, porque uma intervenção cirúrgica num paciente com pressão mais baixa, sempre você tem um certo risco e preocupação de o paciente desenvolver maculopatia hipotônica, perder visão central e você entra numa espiral de problemas, né? Por outro lado, uma outra coisa importante a se considerar é a questão sistêmica do paciente. Então, eu só queria rapidamente comentar sobre duas coisas. Primeiro, a questão da pressão arterial do paciente. Então, esses pacientes é importante fazer mapa. Eu acho que são pacientes que merecem, pelo menos uma vez, ter uma avaliação com a monitorização da pressão arterial. E, se necessário, isso pode ser repetido. Paulo Augusto já falou sobre a apneia do sono. E o outro ponto é o maleato de timolol. Tá? A gente tem tido cada vez mais evidências recentes, o Felipe Medeiros comentou recentemente num trabalho deles sobre o papel de vilão que o maleato de timolol está tendo em pacientes com glaucoma de pressão normal, por conta do perfil de redução pressórica e do efeito sistêmico que ele tem nesses pacientes, criando uma situação de condição ruim para o disco óptico e nervo óptico, especialmente à noite, né? Então, é outro ponto importante a se considerar. Mas aqui, nesse caso, acho que você já colocou, o paciente pode ter não utilizado direito a medicação, né? A fidelidade ao tratamento pode ter interferido também, mas considerando o nível de comprometimento, muito provavelmente a gente não vai escapar de uma intervenção cirúrgica, né? Então, acho que é importante ponderar isso.
Ela chegou a fazer o mapa, acho que o Pedro comentou, é que a gente não escreveu, mas ela tinha uma redução de 16% na pressão arterial sistólica e 24% na diastólica à noite. Só que ela não tomava, ela não é hipertensa, então aí também não ficamos meio sem ter como intervir nessa questão.
Tem agora colegas da cardiologia que se preocupam muito com essa questão da desregulação autonômica, né? E tem até como tratar isso, né? Então, muitas vezes a gente acaba sugerindo para passar com um colega que tem experiência nisso e que eventualmente pode considerar ou não, dependendo do que ele fizer dos outros testes, tipo tilt test, outras coisas, se vale a pena para esses pacientes fazer uso disso. E às vezes, né, eu tive um caso recente de uma paciente jovem com glaucoma de pressão normal, que é meio incomum, mas que o grande vilão era o maleato de timolol afetando a pressão arterial dela, né? E a gente tirou e depois refez o mapa, a pressão arterial dela voltou a se normalizar. Foi algo bem, bem diferente, mas é sempre bom ter um cardiologista para ajudar, né?
Sim, com certeza.
No final, nessa parte do tratamento, quanto que tá a pressão, hein?
A última
E
consulta,
quanto que é a espessura de córnea?
575 no olho direito e 500 e...
13,16.
Ela tá uma pressão que a gente já não fica com tanto receio, assim, de para quanto vai, né, por causa da cirurgia. Eu tenho receio alguns pacientes que com 9, 11 de pressão, com progressão, e, bom, vou fazer uma trabeculectomia para realmente essa pressão vai para quanto, né? Mas aí, Luiz, o que você faria agora? Eu acho que vai para cirurgia, não?
Eu queria só chamar a atenção aqui, o acometimento assimétrico entre os dois olhos e a progressão muito assimétrica entre os dois olhos, né? Porque mesmo que a pessoa pare de usar a medicação, ela não vai dizer, vou parar só no direito, no esquerdo, eu vou continuar usando. Isso não existe. Então, ela vai parar nos dois e tem uma diferença ali gritante, né, entre os dois. E para o lado direito, me preocupa bastante, porque ela começou com escotomas paracentrais profundos. Se a gente olhar ali, ó, o nasal superior está bem deprimido ali. Se avança um pouco mais, vai começar a cair a acuidade visual dela, né? Se começar a atingir a parte central. Então, isso é uma coisa importante. Como tem essa simetria, chegou a pensar em fazer dupla de carótida e tal? Fez e tal.
Investigação de glaucoma secundário também, e ela fez Doppler de
E
carótida.
no.
E não deu nenhuma obstrução significativa, né?
Não.
Clinicamente significativa.
Perfeito. E o horário aqui, vamos dizer assim, que um glaucoma seria mais importante para ela seria provavelmente de madrugada, quando a pressão arterial está mais baixa e a pressão intraocular está mais elevada. Então, vai diminuir o fluxo. Aqui a gente teve da pressão arterial, a gente teve a medida porque fez um mapa com descenso noturno acima de 20%, que é considerado patológico para a gente, né? No caso, que o normal é entre 10% e 20%. A gente não tem a medida de madrugada da pressão intraocular dela, mas provavelmente pode estar acontecendo alguma coisa aí. Então, em relação a equilibrar essa pressão ao longo do dia, eu acho que uma cirurgia, como o Ivan tocou no assunto e o Vessani também, seria uma coisa a se considerar nesse olho direito. Assim, eu falo, uma trabeculectomia, uma cirurgia nesse
Se
sentido.
nós afastamos glaucoma secundário pelo exame oftalmológico, um glaucoma secundário a uma doença sistêmica, talvez o decúbito tenha alguma explicação que possa ajudar nesse raciocínio. O hábito do decúbito
Exato. Às vezes a gente pode perguntar para o paciente se ela tem alguma preferência de lado para dormir ou não? Como é que ela dorme? Porque existe alguns estudos com relação a esse tipo de coisa, né?
Professor Shukla would like to comment on this likely normal tension glaucoma patient with maximal therapy, topical therapy, and the previous SLT. And I have a... Enquanto isso, eu tenho umas questões aqui. Acho que é o professor Belfort perguntando se repete o SLT. E a professora Vilma pergunta se faz diretamente ao Vessane, se faz mineralocorticoide sistêmico. Já que você falou tanto dos cardiologistas, você vai gostar de responder essa.
Sim,
Foi a Vilma.
se ela não faz uso de antipertensivo, Vilma, opa, dá para me escutar?
Eu estou surdo, então.
Eu acho que é possível considerar sim, mas sempre com o apoio de um colega da cardiologia que tenha experiência com isso, né? Eu nunca prescrevo, né? Eu tenho uma colega que a gente costuma encaminhar e aí ela avalia e decide, né? Mas é um mineralocorticoide de baixa dose, né? Para o paciente utilizar e ser reavaliado, né? Através de mapa e de outros testes que eles fazem para verificar se o paciente teve alguma melhora. Porque nesse caso em especial, né, como vocês mostraram, a paciente tem a alteração, mas não tem como tirar remédio ou trocar remédio, né, que a gente vê às vezes um paciente tomando antipertensivo e ter esse efeito ruim do ponto de vista oftalmológico, né, não necessariamente do ponto de vista cardiológico. Os cardiologistas, para ele tendo uma redução, um descenso à noite é bom, né, é cardioprotetor, mas sim. Agora, em relação à SLT, a minha experiência não é muito boa com os glaucomas de pressão normal. A literatura também fala a mesma coisa. Em geral, os que têm pressão um pouquinho mais alta, nesse caso, o paciente tem quanto de pressão?
Inicial dela era 18.
18. Talvez tenha uma chance maior, poderia ser considerado sim. Eu acho que o professor Rubens levantou uma boa ideia antes de se pensar numa trabeculectomia, poderia dar essa alternativa ao paciente, é menos invasivo, é mais seguro, e eventualmente o paciente responde sim, né? Mas em pacientes com pressões mais baixas, normalmente a resposta é bem pobre, né?
A gente
Nossa, Marlene. Marlene vai te ajudar a fazer.
Ótima discussão. A gente já estourou o tempo desse primeiro caso. Eu só queria comentar do mineralocorticode, Vilma. A gente teve um CIMASP uma vez que chamou alguns professores, né, de outras disciplinas, e ele ficou meio bravo. Eu esqueci quem era agora, era da cardio daqui, quando a gente fez essa pergunta para ele. Ele disse que bom, pelo menos deve ser a opinião dele, né? Então, ele achou assim meio agressivo fazer isso, vamos colocar. Né? Se você tentar aumentar a pressão sistemicamente. O que a gente tenta mais é readequar as medicações, né? Principalmente as noturnas, aí junto com o cardiologista, evidentemente, ou com o nefrologista que acompanha o paciente. Tá? Obrigado, gente. Vamos trocar por causa do tempo.
Good evening. My name is Sergio Nakamura. I'm going to present I am second year resident in the service. Today's ground is going to be sternocalcular diseases and cornea. My supervisor was Dr. Mauro Campos, and the head of the department is Dr. Flávio Irai. So, The case concerns a 39-year-old woman born and raised in São Paulo who was referred from the emergency department with complaints of edema and ocular irritation in the left eye for approximately 10 days. She denies any ophthalmologic history, reports hypertension and dyslipidemia, and denies any family history of ocular diseases. On ophthalmologic examination, the patient has a best corrected visual acuity of 20/20 in both eyes and an intraocular pressure of 15 in both eyes. I will present the ectoscopy and the anterior segment zip lamp photographs shortly. The fundus examination reveals a well-defined optic disc with physiological cupping, vessels and macula without abnormalities, and an attached retina. So this is the ectoscopy.
Everyone, my name is Rodrigo. I'm first year resident and the service. And on the ectoscopic exam, you can see the patient's left eye has an edema in the upper eyelid.
It is not possible to see on the image, but on palpation, the patient presents with left preauricular lymphadenopathy. This is the slit lamp of the right eye.
In the slit lamp exam, we can see the exam is normal, is a clear conjunctiva, clear cornea, forming anterior chamber, basically, and the patients appear to be phasic. And you can see here in the upper tarsal conjunctiva, hyperemic of 1+.
The left eye.
The left eye is normal, similar to the right eye. And in the upper tarsal conjunctiva of the left eye, you can see it's more hyperemic than the right eye and has a granulomatoso lesion.
So for diagnostic hypothesis,
Good evening, everyone. My name is Thiago. I'm a second-year resident. So for diagnostic hypothesis, we have a patient that presented to us with preauricular lymphadenopathy associated with unilateral granulomatous conjunctivitis. So we might consider patino-ocular glandular syndrome. So taking this into account, we have to consider infectious causes as the main hypothesis. So Bartonella, syphilis, tuberculosis, also fungal causes such as Sporotrichosis, and maybe also viruses such as herpes infection.
as previously mentioned, the main syndromic hypothesis for the patient is patino-ocular glandular syndrome. Therefore, it's important to take into account the possible causes of the syndrome, which include infectious agents such as Bartonella, Henselae, syphilis, tuberculosis, Sporotrichosis, and herpes virus. Non-infectious causes should also be considered, such as calazium, ordellum, or tumor. Initial management.
My name is Carolina. I'm a third-year resident. So first of all, I will try to go back to the anamnesis and try to think about some risk factors such as contact with cats. And I will also try to see other lesions over the body. And then I will try to rule out some infections, so as tuberculosis and syphilis. And then
So the laboratory tests, including complete blood count, tuberculin skin test for syphilis, and serologies for Bartonella showed no abnormalities. During the consultation, the presence of lesions in other parts of the body, such as the skin, was investigated, and the patient reported a superficial ulcerated lesion with perilesional erythema on the left forearm for the past 2 weeks. The patient was also asked if she had any pets and whether they showed any lesions. She then reported owning a cat with a localized crusted ulcerative lesion with superficial necrosis on its nose. The cat had been evaluated by a veterinarian, and a biopsy confirmed the diagnosis of Sporotrichosis. The cat began the treatment approximately 2 days before the onset of the patient's symptoms. So, for the therapeutic plan, based on the patient physical examination findings and the clinical history of her cat, treatment with itraconazole 150 milligrams every 12 hours for 2 months was initiated. The patient was also referred to an infectious disease specialist for systemic evaluation, and a follow-up visit was scheduled for 1 month. The patient only returned after 2 months with improvement of her symptoms and complete resolution of the granulomatous lesion on the superior tarsal conjunctiva of the left eye. So, for the discussion, the image on the left shows the progression of sporotrichosis in Brazil. It is important to note that before the 90s, there were not as many reported cases, which does not necessarily mean the disease was absent in those regions. Since the 1950s, sporotrichosis in Brazil has evolved from a sporadic environmental disease to an urban zoonotic epidemic, primarily driven by the transmission of infected cats to humans. Initially here, the feline and human cases began to increase during the 1990s and 2000s, with the Rio de Janeiro region standing out due to a significant outbreak recorded between 1998 and 2004. Currently, the disease is hyperendemic, especially in southern states, with the species Sporotrichosis brasiliensis responsible for most infections. The increase in cases has led to mandatory reporting in some states and integrated public health actions, highlighting the importance of controlling the disease in both animals and humans. This image right here shows the distribution of human sporotrichosis cases in Brazil, and this other image shows the outbreaks of sporotrichosis in cats in Brazil. This graph on the left shows the distribution of human sporotrichosis in the state of São Paulo between 2015 and 2024, indicating that 96% of cases occurred in urban areas. The image to the right displays a graph showing the increase of the annual number of sporotrichosis in the state of São Paulo over a 13-year period. This study showed that 97% of the patients diagnosed with sporotrichosis had contact with cats with sporotrichosis, while only 5% had contact solely with contaminated soil. Approximately 86% of infected patients present with granulomatous conjunctivitis, and about 98% of these cases were unilateral. An important finding was acute dacryocystitis, which predominantly affected children. Thank you.
Mauro, o orientador do caso, quer fazer alguns comentários? Quer falar daí? Quer subir ali? Tá bom.
Very interesting case also for our international guests, considering that the disease is reaching US and Canada in these last years. So it started about 30 years ago with some sporadic cases in Rio, and it's spreading out all over Central America and also North America. It's in our cases typical disease, contact with cats and granulomatous conjunctivitis, and that improved under ivermectin medication.
Mais algum comentário?
Eu teria, Ivan, Ana Luísa. Sorry, it's in English.
Não, pode ser em português.
Pode, porque a gente está usando itraconazol também para tratar esses casos mais do que ivermectina. Eu não sei qual é a diferença em termos de evolução da utilização do itraconazol e da ivermectina. Você sabe, Mal?
Para cima. Para cima.
Itraconazol. O paciente foi tratado com itraconazol. Falei ivermectina por engano.
Tá
tempo
bom.
médio de tratamento 60 dias.
Não, aí tudo bem. Não, é que eu achei que tinha um tratamento que eu não conhecia. Tá bom. Ok.
Mas se eu puder só acrescentar uma coisa, posso, Ivan?
Para, Deus.
Só lembrar, primeiro, o diagnóstico pode ser bastante difícil, viu, gente? Aí tinha um gato, tudo bem, fechou bem o diagnóstico, mas às vezes você vem com caso crônico, unilateral, com todos os sinais de esporotricose ou dessa síndrome, e a gente não consegue fazer diagnóstico, né? Ou porque não está procurando o micro-organismo correto, porque a síndrome ela é envolvida com vários micro-organismos, não é só o micro-organismo, o Bacillus rancelae ou o que seja, né? A segunda coisa é que a droga, eu fiquei também meio assim quieta, eu falei, opa, tem alguma coisa aí. Mas uma opção de droga, se de repente você encontrou um paciente que é alérgico, ou sei lá, não tolera a medicação, você pode usar azitromicina em alguns casos, tendo certeza que você isolou o micro-organismo certo, né? Então, é só as contribuições.
Mas para esporotricose, você vai usar azitromicina?
Não,
Não.
para todas as outras
Ah.
hipóteses, porque, como eu falei, nem sempre você consegue chegar no diagnóstico, né? Então, se for um caso que você fecha clinicamente muito bem fechado e você não encontra o micro-organismo, você pode tentar tratamento com azitromicina oral, né? Nada tópico, né, gente? Pelo amor de Deus. É uma coisa que quem já viu é bem assustador. Os gânglios não são pequenos, são gânglios bem significativos, quer dizer, o paciente está com mal-estar generalizado, então é tudo tratamento sistêmico, né?
Denise, no caso de biópsia, onde é que você sugere? O gato, por exemplo, ele fez 4 pontos de biópsia.
O gato?
Tirou o gato. O gato tirou, fez 4 pontos de biópsia. Isso, exatamente. Gato doente. Não era um gato qualquer, o gato doente. No caso, na conjuntivite do paciente, como é que você orientaria a biópsia no caso de você não localizar o gato, não saber que tem um gato na história?
O agente etiológico, né?
Como é que você faria a biópsia? Um ponto
assim,
único, tiraria todo o granuloma?
A indicação da biópsia é no gânglio, né? É claro que tem algumas apresentações de conjuntiva que você pode biopsiar também, e se você tiver sorte, você consegue pegar, seja o que for, seja o micro-organismo que for. Mas o gânglio é o mais indicado para você fazer a biópsia nesses casos. É que eu fiquei surpresa assim com o gato, porque o gato morre, né? O gato é difícil de você, às vezes, identificar na fisiopatogenia da doença. Esse caso é muito fechadinho, bonitinho, mas às vezes você não consegue ter o gato. Então, raramente a gente escuta que o gato foi levado para fazer biópsia, né? A gente sabe mais que o diagnóstico é a biópsia de gânglio, ou a biópsia de um nódulo, como
pode
você
ser
bem falou.
sorologia também.
Não, sim, pode.
Não, a
mas eu falo
sorologia
assim,
para a esporotricose.
Tá, sim.
Porque, assim, o Anderson, que é o micologista da escola, que tem um laboratório específico para esporotricose, ele faz o Western blot no sangue. Nós já fizemos com ele pelo menos 2 diagnósticos, que eu tenho certeza que foram daí. Um eu fiz na clínica, com o Western blot positivo. O grande problema é que ele, como tem um laboratório de pesquisa, e na laboratório central da escola não se faz, ele precisa receber o sangue já retirado. Então, foi um rolo, porque a gente teve que chamar o laboratório central para pegar para colocar o sangue, para mandar para o Anderson, e aí o Anderson fazer o diagnóstico. Não tem isso na rotina. Eu não sei se tem no Fleury.
Acho que o Fleury tem. Fleury tem, eu já tratei com o Fleury. Mas eu não estava falando mais do gato, entendeu?
Isso.
Eu achei... Você está falando do gato ou você está falando do paciente?
Não, estou falando da pessoa.
Exatamente.
Você faz o exame sem fazer biópsia. Sem fazer biópsia, direto da sorologia.
Sim, mas nem sempre você pega. Esse que é a dúvida, né? Às vezes você precisa fazer alguma biópsia no local ou no gânglio, né? É só variação de propedêutica, Ana. Não tô questionando ou criticando nada.
A gente deveria saber exatamente para que laboratório mandar para fazer o exame sorológico quando a gente tiver um caso, porque na escola a gente ainda tem o recurso desse
Não, a
laboratório,
escola.
por favor, mas fora não teria essa pessoa. Então, eu não sei para quem pedir.
E aí, quem preparou o caso aí, deu para saber onde que a gente pode fazer essa pesquisa toda?
Mauro?
Acho que o
Vamos
Grande Round ele tem essa função, né, de
pra
ajudar a
encerrar.
comunidade. Ah, tá. Deixa eu ficar quieta.
O Mauro vai encerrar o
Esse
caso.
caso diagnóstico foi clínico, vamos dizer, baseado na hipótese do famoso gato.
Muito bom. Obrigado. Boa noite. Próximo caso.
Sobre o gato. Antônio, tem gato, cachorro, alguma outra pet? Não? Então tá bom.
Esse foi ótimo.
Pode começar? Pode começar? Tá. Good evening, everyone. My name is Antônio Moraes. I'm a second-year resident of Escola Paulista de Medicina. Today, I present the third case of our service. I'd like to thank my preceptor and chair of the service, Dr. Ivan Marnas Tavares, the head of the division, Dr. Luiz Alberto, and my colleagues, Dr. Bárbara Moreira and Rafael Silveira, for the documentation of the case. Our case starts with a 64-year-old male born and raised in São Paulo who had a chief complaint of low vision on the right eye, resulting on a failed driver's license test. Of personal medical history, the patient has type 2 diabetes and hypothyroidism. His ocular history is positive for glaucoma on both eyes, and he was using latanoprost, brimonidine, and dorzolamide on both eyes at presentation. He had no family history of glaucoma. The patient had best corrected visual acuity of counting fingers on the right eye, 20/25 on the left eye, intraocular pressures of 12 millimeters of mercury on the right eye, 10 on the left, as well as a relative afferent pupillary defect on the right. His central corneal thickness was 513 micra on the right eye and 519 on the left. I'll show photos of the anterior by microscopy, gonioscopy, and fundoscopy of both eyes.
Right, everyone. My name is Vinicius. I'm a first-year resident here at Escola Paulista. So in the right eye, we got a slight hyperemia in the conjunctiva, a clear cornea, a formed anterior chamber, trophic iris, and the patient looks to be phakic.
And for the left eye?
In the left eye, it's similar. We cannot see details of eyelashes and eyelids, a clear conjunctiva, clear cornea, a formed anterior chamber, and appears to be phakic.
Okay.
You're
Again,
very kind. You cannot see anything there.
yeah, the lighting of the left image was not the greatest, but again on the left, again on the slit lamp examination, we can see a formed anterior chamber and confirm that the patient is phakic.
Again with cataracts, huh?
Yeah, cataract. On the right eye gonioscopy.
So in the right eye of the gonioscopy, we can see an open angle into the ciliary body, 360 degrees. And for the left eye, it's pretty similar. We got open angle into the ciliary body, 360 degrees.
And you should say also a mild pigmented trabecular meshwork.
Yeah.
Because it's important if you want to perform SLT or some angle surgery.
Okay, for the fundoscopy.
We can see optic disc with sharp margins and alpha and beta atrophies. It looks like completely excavated. And in the past image, we can see increased reflectance on the vessels and decreases reflex on the macula. Also, the retina is attached.
And for the left eye?
In the left eye, we can see a pink optic disc with also alpha and beta atrophies. The cup-to-disc ratio is something about 0.8, and the vessels also got reflectance increased, and the macula decreased reflectance, and the retina is applied. Patch.
Sorry. For the diagnostic hypothesis.
My name is Wakana. I'm secondary resident. So we have a 64-year-old male patient complaining about low visual acuity in the right eye, associated with a cup up to disc of 0.9 in the right eye and 0.8 on the left eye, and a normal IOP. So we can think about a normal tensile glaucoma, or also an primary angle glaucoma, and also a large physiological cup. And also we have to think about any neurological disease or neuropathy.
Yeah, that's pretty much it. And for the management. Okay. Again, for the diagnostic hypothesis, we had low visual acuity on the right eye, neurological diseases affecting the optic nerve, and glaucoma, maybe mainly primary open-angle glaucoma or normal tension glaucoma, and less likely a large physiological cup. And for the management.
Good evening, everyone. My name is Jose. I'm a third-year resident here at service. At first, I would ask for CCT for both eyes, visual field, Goldman visual field for right eye, and 24-2 for left eye. I would also ask for a retinography and OCT ganglion cell complex and nerve fiber layer.
Yeah. So this is the first appointment we had with this patient. He had an intraocular pressure of 12 and 10 on using 3 IOP lowering medications. We requested visual fields, OCT, retinography, and pachymetry, both of which we've already seen. And we also scheduled a second appointment for 3 months, maintaining eye drops in use. And the patient returned as requested 3 months later and showed us visual fields performed on a different clinic. On the right eye, the Goldman visual field is compatible with a constricted visual field with remaining temporal inferior visual eyelid. On the left eye, we have a reliable 24-2 exam with the formation of a superior arched defect. For the OCT, we have a diffuse and significant thinning of the retinal nerve and fiber layer with increased cup-to-disc ratio on the right eye and important reduction of the ganglion cell layer thickness. Even though there's a mistake on the segmentation of the right eye exam, these findings are compatible with bilateral optical neuropathy, likely to glaucomatous damage or compression. We asked for advice from our colleagues on neuroophthalmology. They ordered cranial and orbit images to rule out compression. The images showed slight thickening of the optic nerve bilaterally without any signs of compression. Neuroophthalmology suggested investigation of normal pressure glaucoma with home blood pressure monitoring of arterial pressure that showed normal pressures throughout the day. At this time, 3 months later, the patient had stopped latanoprost on his own, but maintained intraocular pressures of 10 and 9 millimeters of mercury. With normal tension glaucoma as our primary hypothesis for the case, we suggested a washout of both brimonidine and durzolamide to discover his baseline IOP, requesting follow-up after a week. The patient returned after a week without any IOP-lowering medications, maintaining intraocular pressures of 12 on both eyes. Now that we discovered that his baseline IOP, we introduced travoprost and scheduled a new appointment after 2 weeks for intraocular pressure measurement. The patient returned 2 weeks later in March 2025 with intraocular pressures of 9 millimeters of mercury on both eyes while in travoprost monotherapy. At this point, we must ask, should we consider adding brimonidine? Should we perform selective laser trabeculoplasty? May this procedure be appropriate in this case, or is the IOP already sufficiently low with the eye drops alone? What about alternatives or adjunctive therapies such as ginkgo biloba, nicotinamide? Are they worth considering in this scenario? Are there any lifestyle modifications that could support optic nerve health, such as reducing caffeine intake, practicing meditation, or engaging in regular aerobic exercise? And finally, What would be the best strategy to follow up? Should we repeat the OCT and visual fields in 3 to 6 months? Should we monitor more closely despite low IOP, given the structural and functional findings? Further discussion, glaucoma is a bilateral but asymmetrical disease, so it's important to correlate structural and functional changes for the diagnosis and follow-up of this condition. This article uses OCT to examine the anatomy of the macula of both healthy and glaucomatous eyes, and the authors compare thickness of the nerve fiber layer and ganglion cell layer in these two groups. They also examined the relationship between structural damage to the macula and functional damage to the visual field. We know that the superior and inferior quadrants of the discs are more vulnerable to glaucomatous damage. On average, the center of the optic disc falls about 6 degrees above the horizontal midline through the center of the fovea. This anatomical asymmetry is the basis of the asymmetrical representation of the upper and lower macular regions on the optic disc. As long as the axons from the ganglion cells in the inferior macular retina enter the high-risk inferior region of the disc, they are more likely to produce superior defect on the central visual field. So here we see a representation of this vulnerable zone. The region of the macula that is most likely to be damaged by the glaucoma falls within the red borders. As the 24-2 visual field has only 4 central points, this defect may be missed, what does not happen with the 10-2 visual field, which has 32 points. So we should consider switching to or adding a 10-2 visual field when the OCT macular scan shows an abnormal region in the retinal ganglion cell analysis, if there is an abnormality in the temporal sector or maculopapillary vulnerability zone on the retinal nerve fiber layer analysis for the disc OCT, in patients with suspected or confirmed normal tension glaucoma, or if there is a visual acuity that cannot be corrected to 20/20. Furthermore, normal tension glaucoma is a diagnosis of exclusion. It is important to rule out other conditions, such as primary open-angle glaucoma with variable IOP or a central corneal thickness that is actually thin, previous ocular hypertension resulting in burnout, optical neuropathies of ischemic, inflammatory, infectious, or compressive origins, systemic events such as hemorrhages, shock, hypotension during the night, systemic diseases such as arteritis, multiple sclerosis, or meningeal conditions, and the night use of beta blockers causing low blood pressure and thus low ocular perfusion. For the treatment, lowering IOP is the only intervention that proved to be beneficial. We aim to lower 30% of the baseline IOP. That's why we perform the washout to discover the patient's baseline. Surgery is indicated if there's damage progression and the patient is on his IOP target. And when it comes to ocular blood flow, the current evidence is still limited. Some agents are being investigated, such as the previously mentioned ginkgo biloba, calcium channel blockers, and betaxolol, but none have yet shown conclusive benefits in clinical practice. In terms of neuroprotection, the most reliable and widely accepted strategy remains the reduction of intraocular pressure, which is considered inherently neuroprotective. While medications like brimonidine and memantine have shown potential in experimental models, they have not yet been validated for clinical use in glaucoma management. That's about it. Thank you.
Então, obrigado. Mais um ótimo caso. Aqui a gente tem outro caso de glaucoma de pressão normal, mas com uma baixa visual importante num dos olhos, né? Com a perda da fixação, provavelmente pelo glaucoma, tem uma escavação total e sem outros achados. Mas ainda não tem segmento para dizer se está estável ou não o olho esquerdo, principalmente, né? Então, a gente teve uma redução de menos de 30% da pressão basal, né? 12, né? Daria 3,6. Vessane, o que você faria nesse paciente? Acompanharia mais? Além de acompanhar, você faria algo a mais?
Não, esse é um exemplo um pouco mais extremado do caso anterior, né? Porque aqui a gente está falando de pressões bem mais baixas. Então, o primeiro passo quando você atende pela primeira vez um paciente como esse é tentar realmente excluir causas que pudessem ter levado a um aumento da pressão intraocular, né? como foi colocado aqui, burnout glaucoma, o paciente usou corticoide, alguma coisa que ele fez diferente e pode ter, por um período prolongado, causado esse tipo de situação. Mas uma vez excluído isso, eu sempre tenho a preferência por tentar medidas menos agressivas, porque primeiro você tem que monitorar o paciente por um tempo um pouquinho maior para definir a evolução do paciente. Apesar de ele já tem defeito no 10.2, já? Não, eu não vi
A gente não tem o resultado ainda
da perimetria, né?
Isso.
Só do 24, tá? Então, a primeira coisa é verificar como é que está o campo 10.2 do paciente, porque tudo bem que a gente não atingiu o valor pressórico ideal com o tratamento clínico, né? Mas o paciente saiu de 12 para 9, pode ser que tenha algum benefício em termos de controle da doença, e uma das coisas que vai balizar a agressividade do tratamento é ver o risco de perda de visão desse paciente central, e o 10.2, uma vez você tendo feito o 24.2C ou 24.2, é o próximo passo para investigar isso, né? Mas eu sempre tenho a percepção de não querer intervir nesses pacientes, a não ser em situações mais extremas de piora no 10.2, e aí você não tem muito o que fazer, porque se a gente está falando de pressões muito baixas, né? O ajuste pressórico é algo muito difícil de se fazer numa situação dessa. Outra coisa, Ivan, ele chegou a fazer alguma avaliação, a gente tem só paquimetria, né? A gente tem alguma outra medida tonométrica diferente, tipo o Hora ou algum dos outros aparelhos mais novos?
Não,
Para
doutor.
tentar, de repente, ver se o paciente tem um comportamento diferente na biomecânica da córnea. Assim, no final não vai trazer muita coisa do ponto de vista prático, mas para entendimento, às vezes você consegue imaginar que talvez esse valor pressórico não seja verdadeiro, né?
Eu acho que esse é um ponto importante, já te interrompendo sem querer te interromper, porque não coincidentemente tem 3 chefes contínuos aqui do setor de glaucoma, né? E nenhum de nós investiu ou pediu para investir em nenhum desses aparelhos, né? Então a gente tem se baseado na tonometria de aplanação de Goldman, na tonometria de rebote em alguns pacientes e na espessura de córnea, né? Há muito tempo a gente tinha hora, fazia hora, a gente desistiu do modelo antigo ainda. Eu queria até que vocês dois comentassem sobre isso. E se o Luiz faria mais alguma coisa, e depois tem a última palavra do Paulo Augusto.
A gente tem alguma evidência, né? E alguma não, tem várias evidências, né, de que não é só uma questão, algumas informações da propriedade biomecânica da córnea podem ser fatores de risco não só para o diagnóstico, como para a progressão da doença, né? O problema é que os equipamentos que são desenvolvidos para fazer a medida dessas informações, eles ficam mudando, como do próprio caso do Hora, né? A gente vai tendo mudanças e essas informações vão ficando meio, quer dizer, do ponto de vista prático, a gente não tem nada de longo prazo que a gente utilize de forma consistente, né? E um dos grandes problemas da gente no glaucoma é que tudo que a gente tem de informação e conhecimento mais robusto, de ensaio clínico randomizado, é com um aparelho tradicional. Mas acho que tem que pesar um pouquinho esse entendimento da informação da biomecânica da córnea, especialmente em casos assim. Eu acho que é algo para a gente considerar em situações especiais, não estou dizendo para todos os casos, mas eu acho que é importante. Uma outra coisa é tentar obter um pouco mais de informação pressórica, tá? Esses pacientes merecem, na minha opinião, medidas pressóricas em período de tempo maior. A gente antigamente fazia-se muito mini curva, né? Curva tensional diária modificada, e hoje não se faz mais tanto. Não é prático, às vezes não acrescenta tanta informação, mas em casos com pressões muito baixas, sem medicação, eu acho que é importante você ter uma noção do perfil pressórico do paciente no período da manhã até o final do dia, mesmo que não seja uma informação completa, né? Há quem até proponha fazer medidas 24 horas, mas é muito difícil de se fazer isso em São Paulo, né? Tem um outro centro por aí no Brasil que faz, mas é difícil. Mas pelo menos uma medida, múltiplas medidas durante o dia em casos mais difíceis como esse, acho que vale a pena para você entender se tem algum momento de escape, né?
Paulo Augusto.
Rapidamente. Roberto, ele parece não ter uma diferença grande entre a córnea de um olho e outro, pelo menos pela microscopia. E tem pressões iguais praticamente dos dois lados. E ele tem um glaucoma muito mais avançado um lado que do outro. Então, não teria muita preocupação em saber se um olho desenvolveu glaucoma, assim, por essa alteração que ele pode ter apresentado. Parece ter pressões mais ou menos iguais dos dois lados, com córneas semelhantes. Então, eu não fico muito preocupado com isso. Mas o que eu insisto nesses casos é que é fundamental a educação do paciente. A educação do paciente tem que ser um processo educacional de várias vezes, porque ele tem uma grande chance de ficar cego.
Só fazendo algum comentário, tirando um pouquinho da pressão intraocular, que já foi comentado bastante, né, na parte da propedêutica, a questão de tentar fazer outras medidas que você colocou, Anthony, no seu slide, para poder, como, por exemplo, meditação, que vai poder... Você tem alguns estudos demonstrando que pode reduzir a pressão intraocular, mas aí você entrou em outras drogas que poderiam ajudar no glaucoma. Aí você colocou uma delas que foi o ginkgo biloba. A gente tem ensaios clínicos randomizados, até com crossover, mostrando benefício, mas tem vários também que não mostram benefício algum. Então, tem que ficar atento que não é uma droga inerte, né? Então, você usar o extrato de ginkgo biloba pode causar alguns efeitos colaterais, né? Por conta vamos dizer assim, com a facilidade de sangramento do paciente, tá? Então, não é para prescrever toda hora. Você tem outros, por exemplo, sulfato magnésico, que também não está ainda muito definido se funciona ou se não funciona, provavelmente não, como a gente espera. Você tem bloqueador de canal de cálcio também, isso descrito na literatura. E agora, mais recentemente, a gente está vendo outras drogas, outras coisas que podem fazer uma neuroproteção, como, por exemplo, nicotinamida, mas que eu vou deixar para o Ivan falar um pouquinho, que vai ser tema dos próximos...
Próxima palestra. Bom, então essa foi a parte de casos clínicos. Agora, we're gonna change to the English part of the go round. Our first speaker, it's an honor to have Professor Eike Shukla, Professor of Ophthalmology from Columbia University, and principal investigator from the nicotinamide study with us tonight. And I would like to invite you to give us your lecture. Thank you very much for coming.
Good evening. Thank you so much for having me, and really a big thank you for the invitation. It's really an honor to speak to all of you, and I'm looking forward to our conversation. So I will start sharing my slides. Are you able to see these?
Yes.
Okay, great. So good evening. The title of my presentation is Neuroprotection in Glaucoma, is Nicotinamide the Answer? And I know that we were talking about this a little bit during the cases, and I'm looking forward to discussing more. So we feel that this is really the next frontier in glaucoma. It's an opportunity to prevent glaucoma progression using an IOP-independent mechanism. And much of this is a collaboration with basic scientists and clinicians around the world. Here are my financial disclosures and some of our departmental disclosures, none of which are relevant to the study. We know that conventional IOP-lowering therapy can slow or halt disease in glaucoma. And this is what we commonly prescribe: drops, lasers, incisional surgeries. But many patients experience optic nerve damage and visual field loss even once IOP reduction has been substantial. And this begs us to ask, can we target the site of damage, the neurons, directly? As you may have guessed, our focus today is neuroprotection in glaucoma. While the creation of therapies to regenerate RGCs has been on a priority at the National Institute of Health, as well as many other organizations for many years, there are currently no approved therapies that directly target retinal ganglion cells for neuroprotection or neuroenhancement in glaucoma. We'll dive right into some of the glaucoma neuroprotection clinical trials, because as we know, there's a strong unmet need for neuroprotective pressure-independent agents in the three categories mentioned in the slide before: neuroprotection, neurorecovery, and neuroregeneration. The first study we'll talk about is the LOGITS trial. This was a low-pressure glaucoma treatment study. This compared brimonidine and timolol in low-tension glaucoma with an endpoint that was not pressure reduction, but visual field progression in the 190 participants that were in this trial. It was found that people who were randomized to timolol were more likely to progress than those randomized to brimonidine, pretty significantly so. Next, we'll talk about the memantine trial. This trial randomized a large group of patients, over 2,000 patients, to 2 different doses of memantine versus placebo. And using lessons learned from the LOGITS trial, it had a similar visual field main outcome measure. They were looking at visual field progression at 4 years at the conclusion of the trial. And progression was declared if the same 5 or more visual field locations demonstrated significant reductions from baseline. Unfortunately, the memantine trial was not found to have a significant effect on glaucoma progression at 48 months, so there really wasn't much value in giving memantine to patients with glaucoma. Another trial looked at topical recombinant human nerve growth factor for neuroenhancement of the retinal ganglion cells, did not find any structure function improvement that had statistical significance, and the authors concluded that larger clinical trials were warranted in this area. Dr. Goldberg may have more to say about this trial and others because he did lead many of them. Another trial from Dr. Goldberg's lab was the CNTF, ciliary neurotrophic factor implant trial for primary open-angle glaucoma. 11 patients underwent an intravitreal implant in one eye, and they were looking at improvement in structure and function as compared to the fellow eye using many of the indices that we're familiar with, including visual field index, mean deviation, RNFL thickness. This trial demonstrated that this was a well-tolerated implant. The most common implant-related adverse effect was meiosis, and no eyes required an explant. But overall, it was found that the mean RNFL thickness in the study eye was higher than the fellow eye. Some of these trials showed an effect, others didn't. They all faced challenges. Some of these are listed here. There really are so many challenges facing glaucoma neuroprotection clinical trials, and you'll see some of them as I talk more about the nicotinamide trial. In a 2012 publication, Harry Quigley describes some of the challenges that are associated with studying glaucoma, specifically studying glaucoma. Hi. Oh, sorry. I thought I heard someone. Dr. Quigley talked about specific challenges associated with studying glaucoma neuroprotection, and some of these are listed here. He described considering a futility trial prior to a full-blown phase 3 trial with specific parameters that allow for detection of a difference between 2 groups, as well as statistical considerations, and considering terminating early if a significant effect is not seen early on. He calculated varying sample sizes based on visual field worsening rates, suggesting that if people, including people that were more likely to worsen, including those with a strong family history, those who had pseudoexfoliation, etc., to allow for an easier detection of difference between the group that was receiving the neuroprotective therapy versus placebo. And some trials have taken this advice to heart and are actually not providing standard of care IOP lowering treatment. We'll mention this a little bit more as we move on to nicotinamide. So on to our topic of interest, nicotinamide. Nicotinamide potentially targets 2 areas, both aging and mitochondrial health. There are overall several neuroprotective targets: retinal ganglion cell health, energy metabolism, ocular perfusion, the integrity of the lamina cribrosa, and more. We know that mitochondrial damage in glaucoma actually predates neurodegeneration and impacts apoptosis. The RGCs degenerate in glaucoma, but the first changes within the RGCs occur in the mitochondria. And this negatively impacts cellular metabolism and energy supply, contributing to cell death. This publication by Simon John and Pete Williams demonstrated the effect of nicotinamide in preventing the development of glaucoma in mice. The nicotinamide effect included both nutritional supplementation as well as they employed gene manipulation, and they structured optic nerve structure and functional outcomes in mice. They found that nicotinamide is essential for many biochemical reactions, including energy metabolism. It's critical for mitochondrial health. Nicotinamide itself is the amide form of vitamin B3. It's readily absorbed from food. It's considered generally safe. DBA2J mice develop progressive eye abnormalities that mimic human glaucoma. So these were kind of the perfect mice to study using nicotinamide. These heat maps of gene expression changes for nicotinamide-treated samples were remarkably similar to those without glaucoma. So in the center, you can see the gene expression map from a mouse that has glaucoma, and on either side, you can see one from a control mouse and one from a mouse that has glaucoma that was treated with nicotinamide. And the control mouse and the nicotinamide mouse really do match. In fact, there are only two genes that are expressed at a significantly different level between the nicotinamide-treated glaucoma mouse and the no glaucoma control sample. Here we can see the mitochondria from control and nicotinamide mice, glaucoma mice that were treated with nicotinamide. The normal mouse is on the top, normal mouse mitochondria is on the top. The glaucoma mouse treated with nicotinamide mitochondria is on the bottom, and you can see that these are really quite similar, especially as compared to the mouse with glaucoma that was not treated with nicotinamide, which is here in the middle. So nicotinamide really did have a pretty remarkable effect here. And what we can see is that 93% of eyes on the higher dose of nicotinamide actually did not develop glaucoma, which was a remarkable 10-fold decrease in risk as compared to the eyes of the DBA2J mice that did develop glaucoma because they were not treated with nicotinamide. The utility of nicotinamide has been found across specialties, not just in ophthalmology, of course, but cardiology, dermatology, and there really has been an explosion of publications over time on this compound. And a few of these have touched on the safety of nicotinamide given at high doses, such as 3 grams per day. Guidance and papers have mentioned that the low mouse dose of nicotinamide that protected against 70% of glaucoma formation was equivalent to 2.7 grams per day in humans, which is just under the dose that's been studied in many of these trials on nicotinamide, but is still 150 times the daily recommended dose of this compound. So in order for nicotinamide to be considered a real treatment in glaucoma, it needed to be tested in clinical trials. This was a phase 2 trial led by Dr. Gus de Moraes at Columbia. In this trial of 32 patients, they were 2-to-1 randomized to nicotinamide 3 grams per day, as well as pyruvate 3 grams per day versus placebo. The two groups were really very similar in terms of their baseline characteristics, and it was found, the endpoint was the number of improving visual field test points. It was found that the patients who received the nicotinamide and pyruvate had almost 3 times more improving visual field test locations as compared to the individuals who received just the placebo. And this corresponds to about 25% of the entire visual field, which is pretty significant in terms of the number of locations where people are potentially seeing better. Although this may not be totally clinically significant for patients, it did give us some signal and showed us that potentially this compound was helping people and could pave the path to bigger things and neuroprotection. Here's another complementary trial. This was a study in Australia by Jonathan Crouston's group, and here they were looking at a number of different measures, but they found improved inner retinal function using ERG in the group that received the nicotinamide versus the group that received the placebo. You'll see here how pyruvate, which was tested in our study, also fits into the story. It's involved in Krebs cycle, allowing for improved energy metabolism alongside nicotinamide. So these two complementary phase 2 trials now have shown similar results regarding improvement in optic nerve function with the use of nicotinamide. And the idea now was to design a larger human randomized controlled trial with longer term follow-up. And our objective was to see if there's a difference in glaucoma progression between treated and untreated groups. So now no longer looking at neuro enhancement or neuro recovery of sick retinal ganglion cells that were kind of coming back to life in a short-term clinical trial, 8 to 9 weeks, which was previously done. But we were looking for a longer period of time, looking to see whether this compound actually prevents progression of glaucoma. So a longer period of time, such as 20 months, is what we decided on for this study. And we'll go over this a bit more. So there are a number of phase 3 programs going on around the world studying nicotinamide. Our program is in the USA. This is a trial based at Columbia, and Stanford is our partnering site. So together we are recruiting patients. There are a number of other countries as well that are doing this. Most trials are prescribing nicotinamide 3 grams per day, although some have now started to lower doses to 1 and 2 grams per day. Some are using nicotinamide riboside. This is a different form of nicotinamide. And all trials, except for the Swedish nicotinamide trial, allow for concurrent use of IOP-lowering agents. The Swedish trial actually takes away kind of standard of care IOP-lowering agents in those with a new diagnosis of glaucoma. Our study design is a randomized double-masked placebo-controlled clinical trial. We assign participants with open-angle glaucoma 1-to-1, either to nicotinamide and pyruvate or the placebo arms. We're screening patients, and then they're randomized to one of 2 groups. And then they're followed for 20 months with visual field, OCT, ophthalmic exams. We're drawing and banking blood for various analyses, as well as some safety measures. Here is our chart of study procedures. We'll go into this in some detail here. Importantly, we're performing clustered visual field testing to increase our power to allow us to potentially detect a difference between the 2 groups. Our baseline criteria involves having a structure function matching between 10-2 visual fields, which was mentioned in the grand rounds today, as well as OCT. And as mentioned, we're also banking blood. We're looking to see adherence and safety. We want to measure nicotinamide and pyruvate levels in the treatment group. We want to determine if patient response to treatment correlates with an expected improvement in energy metabolism and mitochondrial function, and whether nicotinamide and pyruvate treatment in glaucoma patients changes oxidative damage and DNA methylation. So is the proposed mechanism for nicotinamide really taking place in humans? So to give you an update on our clinical trial, of course, as mentioned, clinical trials are not always easy, especially not those trials on using neuroprotection or studying neuroprotection in glaucoma. Our phase 3 trial, when we had recruited about 50 patients at Columbia, and there were about 300 patients worldwide that were included, we faced an unfortunate case of drug-induced liver injury, which we reported in the Journal of Glaucoma. This was a 73-year-old woman with POAG, had European ancestry, was relatively healthy, had a history of endometrial cancer and remission. She was on a low-dose statin. She had initiated the study drugs and increased her dose in a graduated fashion per our protocol, reached a target dose of 3 grams per day of nicotinamide and 3 grams per day of calcium pyruvate. And after she had been on the target dose for 3 weeks, she reported vomiting for a day and was advised to stop all study-related drugs, seek medical attention immediately. She was found to have very elevated AST and ALT levels and leukocytosis. She had some clotting and bleeding problems as well. She was admitted and treated with N-acetylcysteine for presumed drug-induced liver injury with coagulopathy, and her laboratory workup and imaging demonstrated no evidence of infectious hepatitis, autoimmune hepatitis, or other forms of hepatitis that may relate to that elevated AST and ALT levels, which led us to believe that probably this was related to the study products. So at this point, our team was deciding what to do. We ended up stopping the study and investigating further. We performed a voluntary study pause, informed all the regulatory bodies. We met with our hepatologists and performed a change in protocol. So we now were getting liver function tests at baseline and throughout the study, and then we induced some stopping rules for the as based on liver function tests. We performed internal and external mass spectrometry analysis of the study pills to understand really what we were giving out to patients and whether in fact it was nicotinamide and pyruvate as intended. Luckily, the patient who experienced this serious adverse event had her lab work normalized over time. She was discharged from the hospital within 3 days of admission and then transitioned to an outpatient hepatologist and now sees only her internist. The IRB and FDA allowed study restart a few months after we'd made this voluntary pause. And amazingly, another case has popped up from Singapore, another older woman. In this case, she also had an elevation of her AST and ALT with kind of some obvious gastrointestinal signs. She had a very low BMI of 15, whereas our case in the United States had a BMI of around 23. Of around 25. So this may have been a dose-related effect for this patient, but point being that there are multiple patients who have demonstrated this liver toxicity with nicotinamide. We know that niacin, which is also a form of B3, it differs from nicotinamide, is associated with direct hepatotoxicity. But prior to our study, there really wasn't much that was published on nicotinamide-related toxicity, aside from this article on a graduate student with schizophrenia who was using nicotinamide 3 grams per day, but chose to increase his dose to 9 grams per day and had episodes of elevated LFTs. So what should we tell patients? There are about 3/4 of the US population uses one or more dietary supplements at any given time. Patients are asking us all the time about so-called natural ways to prevent worsening of their glaucoma. And the whole nutraceuticals industry is unregulated. So if the patients are buying nicotinamide off the shelf, we don't actually know what they're getting. Our group published a position statement on the use of nicotinamide for glaucoma neuroprotection and specifically recommended that nicotinamide is not approved for glaucoma. Its safety is unknown. So if doses less than 3 grams per day of nicotinamide are being considered, collaboration with the PCP internist is necessary and periodic liver function testing should be performed. Doses that are considered high doses equal to or greater than 3 grams per day are not recommended outside of the confines of clinical trials where liver function is closely monitored. And patients should be advised of all possible side effects, urged to report them immediately, especially side effects related to liver dysfunction. And of course, patients with current or prior liver disease should not be offered nicotinamide supplementation. Niacin is not at all considered a neuroprotective agent and is known to be hepatotoxic in high doses. Therefore, we strongly recommend against the use of niacin in place of nicotinamide for glaucoma neuroprotection. General, we tell them that nicotinamide holds promise in laboratory and human studies, but the ideal long-term dose is unknown and efficacy and safety continues to be investigated. The lesson learned from all of this is that our clinical trial, the science is very exciting, and we're eager to have nicotinamide potentially be a neuroprotective option for our patients. We really need to balance that with the safety of the compound, which we're really learning more and more about as our trial has gone on. Thank you for the opportunity to present, and I'm happy to take any questions.
Thank you very much. This report is really important. I've seen physicians prescribing 3 grams a day for patients to treat glaucoma, and this position for the American Academy and the American Glaucoma Society is really very important for the community. Dr. Roberto.
Dr. Shukla, thank you once again for your presentation. It was really nice. You gave an idea of how difficult it is to prove neuroprotection in glaucoma. This is not easy. I mean, I remember the first studies with memantine was really tough to see how hard what is to develop the study, and then in the end, here in Brazil we have 2 sites trying to also collaborate with this study, but in the end it was not what we expected. But there's a great hope for nicotinamide, And as Ivan said, because of that and because of the previous publications, some of our ophthalmologists are always thinking about prescribing nicotinamide before the large trials prove something, and this is maybe dangerous as you show us. And can you give us some recommendation in terms of care if someone wants to the doctors, if someone wants to prescribe to their patients despite the fact that it would not be appropriate, but if the doctor insists to try it to their patient, what would you recommend?
Sure, I think that's a great question. And, as we know, it's not always the doctors who are wanting to prescribe it. It's patients come in with these ideas too, because the information is out there. And, they may even consult their AI doctor online and ask us these questions. So we'll definitely be put in this position. So I'll share with you what we're doing in our trial. Like I mentioned, it's not a great idea to prescribe the full dose, the 3 grams per day, but you could consider starting at a lower dose, such as 1 gram per day of nicotinamide. I suggest partnering with the patient's primary care doctor, because there are quite a few liver function tests that one will have to get. And as the ophthalmologist, I'm not sure it makes sense to order this for all the patients and then just be following liver function tests all the time. But what we're doing is we are asking that everyone gets a liver function test done at baseline, including AST, ALT, ALK-Phos. And then upon initiation of the nicotinamide, get tested again a week or 2 later, because some people have been found to have an idiosyncratic sort of effect, the nicotinamide, that they react more quickly, and this may be some genetic predisposition that they have. So 1 or 2 weeks after initiating the nicotinamide, get a liver function test. And then our next test in the study is at about 9 weeks, when we have patients return for their neuro recovery visit. And then after that, we're testing them about every 4 to 6 months thereafter for the 20-month duration of the study. So baseline 1 to 2 weeks after it starts, about 2 months after starting, and then every 4 to 6 months thereafter. And then, of course, avoid it in people who have a history of liver dysfunction.
Okay, the colleague must be very careful if the colleague wants to prescribe that. There's one of our colleagues here, Marcelo Hatanaka. Do you want to comment or make a question?
You're mute.
No sound.
Sorry, can you hear me? Okay. Well, first of all, nice presentation. And what about an even lower dose? Because some eye care doctors are now prescribing about 500 milligrams per day. And I think that maybe subdoses, I'm not sure if I'm just wasting resources in spite of treating.
I think that's a great question. And in the shorter term studies on the mice, as well as on the humans, that Australian trial that I described, as well as the initial trial out of Colombia, it was a short study. So it was 9 weeks. And so we quickly kind of needed to load the nicotinamide on and see if we get any neuro recovery effect. But if somebody's using nicotinamide for the long run, let's say years, they may not need this quick loading of high dose nicotinamide. They may be able to get away with a smaller dose that's used over a long period of time, and it's unknown whether it's going to have a similar effect as the high dose, but we know that it'll probably accumulate in the body to some extent, and may be able to help that way.
And the idea would be to start treating in the beginning of the disease, or would you keep the idea just to start treating in the advanced cases when we don't have anything else to try to do?
Another great question. Obviously great to try to prevent. That's what we're always doing in glaucoma, to prevent further damage. But what we'll find often is that the people who are most interested, certainly people who are most interested in trials, tend to be those who are kind of desperate in a way for some kind of treatment or thinking out of the box. So many people who are further along might be more interested in adhering to, taking 6 or 12 pills a day of this stuff. But it's certainly there are people with earlier damage that we'd want to capture.
About glaucoma science. But I'm wondering if there is any commercially available nicotinamide in US, because if the patients start to hearing about this, I am afraid that they will run to buy this and, you know, take without any orientation or device. I'm just curious to know if they have commercially available nicotinamide.
Yeah, good question. It's available, at really any health food store, even grocery
Oh,
stores,
God.
Amazon, etc. So it's definitely out there. But what's interesting is for the purposes of our trial, despite nicotinamide being available over the counter everywhere and basically being an unregulated food because it's just like a nutritional supplement, in order for us to test it in our trial, we actually needed an investigational new drug status with the Food and Drug Administration. So we have that for nicotinamide, and so that's how we're testing it. But it's out there. Anyone can buy it.
Okay, thank you.
Sure.
Any other question from the audience? No? Professor Chukla, thank you very much again.
Thank you for the
It was a
opportunity.
pleasure to have you with us tonight.
Thank you so much.